Hello, everyone, and welcome to this special edition of Outcomes for Me Ask the Expert webinar series. Today, we are privileged to connect you with a leading expert in breast cancer who is here to address your questions in real time. So thank you for everyone who submitted questions ahead of time, and thank you for everyone who is spending time with us today to be a part of this important conversation. For those of you who may be joining us for the first time, my name is Suzanne Garner. I am Director of Marketing and Community at Outcomes for Me. I'm also a stage 2 breast cancer survivor, and I started working for this company, for Outcomes for Me, after I found it very beneficial in educating myself about my diagnosis. So if you're unfamiliar with Outcomes for Me, it's a platform that's driven by the latest AI technology and is dedicated to empowering cancer patients by providing personalized evidence-based treatment options and vital information. So our goal is to help democratize healthcare, working to ensure that each and every patient has access to information that is safe, evidence-based, and tailored to your specific diagnosis. So we believe in equipping patients with the tools that you need to actively engage in your care and advocate for yourself with a full understanding of your options, as well as access to clinical trials and the newest research in cancer treatment. For today's webinar, I'm honored to welcome Dr. Tiffany Avery. Dr. Avery is a board-certified medical oncologist with a special interest in breast cancer and differences in cancer survival. After completing fellowship training at MD Anderson Cancer Center, Dr. Avery served as an assistant professor of medical oncology at Thomas Jefferson University in Philadelphia and at Wake Forest Baptist Hospital in Winston-Salem, North Carolina. She is currently an advisory board member of Angels Surviving Cancer, a community-based breast cancer survivorship group based in Houston, Texas. In this capacity, Dr. Avery has been an invited speaker to discuss topics that include cancer prevention, treatments, clinical trials, and survival disparities in cancer, and has led grant writing efforts to ensure funding for community-based educational efforts targeted to breast cancer survivors. Dr. Avery is also a co-host of Three Black Docs, a podcast aimed at eliminating healthcare disparity. So welcome, Dr. Avery. We are so lucky to have you. And could you please start us off by introducing yourself and sharing anything may have missed with our community?
Thank you, Suzanne. I don't know that I need to say anything else. I think I think you covered it. Thank you for that introduction. I do want to give you kudos for the work that you're doing here at Outcomes for Me. People listening may have noticed that right now I'm heavily actively involved with community-based groups, survivorship groups, and for patients who are undergoing active treatment. I feel really strongly and passionately about empowering patients, empowering survivors, and really understanding everything you need to when you get this diagnosis. It is overwhelming. It can be quite confusing because there's a lot of information to wade through. I think in a short amount of time when you're trying to make treatment decisions and trying to make informed decisions. So, I just wanted to, again, just draw attention to what you're doing with empowering patients. And thank you for this invitation. I think probably the only thing that I would add to your introduction is that my last position was actually Chief Medical Officer at a company called NantHealth. Where I had the opportunity to work in digital tech, in the health tech space, with kind of the same goal of, how do we work with health tech to be able to drive outcomes in the healthcare system as a whole, and for patients as well. So, but thanks
That's
for the
amazing.
opportunity.
I think there's so much potential there. So yeah,
Yeah, for sure. Yeah,
yeah.
definitely.
Well, you are absolutely correct in that as cancer patients, trying to educate yourself about this diagnosis that you've been given can be extremely overwhelming. For today's conversation, we are not giving you easy questions, but what we're hoping today is to dig into genetic testing. So to start, could you please help us understand the difference between germline testing and somatic testing, and why they should both be considered when someone's diagnosed with breast cancer?
Yep. So this is a great question. And I think this is absolutely fundamental because this is where a lot of confusion happens, I think.
Hmm.
So we know that cancer is a genetic disease, right? If you start with just kind of basic cell biology, cells grow and divide, and we have genes that control that process. And when the genes work the way they're supposed to, the cells grow and divide and stop when they're supposed to. When the genes don't work the way they're supposed to, then cells get the ability to grow and divide out of control. They don't stop when they're supposed to stop. And then you get a tumor in a very basic, kind of simple term. So when you read cancer is a genetic disease, what it means is that something has changed those genes that control that process and led to this tumor forming just from a cell growing out of control. The question before us today and always is, where did that change in the gene come from? It can either be that you were born with it, okay? So you came with some change in one of these genes that controls that process that you inherited. And so it was already there when you were born, and it makes you more susceptible to then go on and develop a tumor sometime in your life. Those are germline mutations. And the way I like to think about it or tell people to think about it is, first of all, the word line is in it. So you can think about family line. And really, germ means sex cells, reproductive cells. So it means these are mutations that are passed down through families. That's germline. So anytime you hear we're germline testing, that means that we're looking for the changes that happen in those genes that you came here with by way of inheritance through your family. Now, when we talk about the other set, and a lot of terms can be used to describe this, somatic is the one you use, which is absolutely correct. You might also hear genetic testing, genomic testing, NGS, next gen sequencing. You know, all of those terms mean the same thing. And that is, we want to see what happened in that cancer cell specifically. So we're taking that cancer cell, we're looking at the genes in that cell and looking for the mutations in that cell. So it wasn't that you were born with certain genetic mutations in place. Stuff happened along the way. Stuff happens, right? The stuff is what we call carcinogens. Okay, so when you hear this is carcinogenic, this is a carcinogen, what we mean are things that can cause damage to DNA that can lead to these changes in the cell. And so when we're looking at genomic testing, we're just looking at that cancer cell to say, oh, these are the mutations that happened in these specific genes that cause this cell to now grow out of control and become a tumor. And so I think, and I hope that sheds some light on it. But whenever you hear germline, we're talking about your family line, what you were born with. Anything else is what happened to that cell once you got here that caused it to inherit, to get, not inherit, see, I already said that wrong, that caused it to have mutations to grow out of control and to form a tumor. The other point that I want to make is that most cancers are actually not inherited. So when we talk about germline, depending on the study, only 5 to 15% of cancers are actually inherited. So the majority of cancers happen because of genetic mutations that have happened along the way in the course of living, in the course of your life, and are not heredity. They're not hereditary. You weren't born with them. Now, I think we're going to talk more about why it's important to do germline testing, even though it's not the majority of cancers. But I just wanted to make that clear from the start. Did that help?
No, it does. It's a very complicated topic, but you explained it very well. I think in a way that's very attainable to patients. So thank you. And I love the tip of the germ line and thinking of a family line. And then
Yeah. Yeah, and I think if you kind of just always go back when you start to hear these terms kind of thrown around, you can always go back and say, okay, are we talking about something that I was born with? Or are we
Hmm.
talking about something that happened to this cell along the way? Like which one, you know?
Yes. Um, okay, so I think that's a good transition into one of our first community questions.
Mhm.
Um, and then I'm going to repeat what you said because I think there's a common misconception that there is a germline genetic like link to most breast cancers, right? And it's really just the opposite because you said
Right.
only 5 to 10. So if you are a woman, maybe you haven't been, or man, and you haven't been diagnosed with breast cancer yet, but there is some family history. What factors determine eligibility for genetic testing in breast cancer?
Yeah, so the first thing to note is that it is most useful to conduct germline testing in someone who has cancer.
Okay.
Okay, that's number one.
Okay.
Um, that is the most useful scenario. So, for this, for what you're doing and who I assume is listening, that these are breast cancer patients or survivors, it is most important for people who have cancer to get germline testing. Now, does that mean that there are not certain family history characteristics where if you don't have cancer, you haven't gotten it, that you should get tested? Yeah, there are, but it's always um, more useful, if you will, in catching a genetic mutation by testing someone who actually has cancer. Um, Now, with that being said, what constitutes a strong family history in general? So that gets thrown around a lot too, right? Of like, I have something in my family. And I told you off camera before we started, I'm Southern, so we talk about this a lot. Your first cousin, second cousin, third cousin, twice removed, and like, how deep do you have to go with everything, right? So if in your family there is a history of young breast cancer, meaning someone had breast cancer under the age of 50, in your close family means first, second, or third degree relatives. Okay, so we're talking about like mom, dad, sister, brother, children, nieces, nephews, great grandparents, first cousins. Once, like me, you start to get to the second and third cousin, we're not talking about those so much, but you're close, kind of your first, second, or third degree relative. So if there's young breast cancer under the age of 50, if there's male breast cancer, so men with breast cancer, in one of those relatives. If you have someone with pancreatic cancer, ovarian cancer, or certain forms of prostate cancer in a close relative, that's also sort of another risk factor. Beyond that, if you have one side of your family, like if you're thinking about it, there's one side of your family that has three or more cancers, that's also
Hmm.
something to consider. Now, with that being said, when you have a breast cancer diagnosis, so again, for the people who are here, who have a breast cancer diagnosis, I assume, then the question of when to do germline testing is much broader. Okay, so in that instance, all of the family history questions still apply, but also if someone is under the age of 50, anyone with triple negative breast cancer would be offered germline testing. There are certain clinical scenarios where germline testing is important for treatment decisions. There are certain ethnic groups, so Ashkenazi Jewish families. There's a founder's mutation that has been identified in those families that lead to a higher risk of breast cancer. So that would be another indication as well. The other important point for patients who are diagnosed with breast cancer is if there's a lobular breast cancer and a history of stomach cancer, an entity called diffuse gastric cancer, that would be another indication for genetic testing. So it is complicated.
Yes, it is complicated to know those different avenues and when you should be advocating for yourself if you have not just
Yes.
naturally been offered it um, through one of your doctors, which does unfortunately happen all the time, depending on where you're receiving your care. So it sounds like because there are so many avenues, it's best just to understand that this line of testing exists, it's important, and that you should just bring it up and have a conversation with your
Yeah,
doctor. Yeah,
absolutely.
yeah,
It doesn't hurt to ask,
right.
when you're diagnosed, do I need germline testing? If you can't remember germline, do I need testing for a family history? Do I need genetic testing for hereditary cancer? Is that indicated?
Okay. So then the next question leads into kind of the so what. So why do we do this? Like, does it impact my treatment decisions? Does it impact my prognosis? What are we looking
Mhm.
for, and what does the how does it impact our treatment?
Yeah, so it's a big so what. So the first thing that is most critical, I think, and time sensitive is that it does impact treatment decisions when you're diagnosed, right? And so the way that can happen is, first of all, it can impact your surgical decision. Maybe you were diagnosed with a breast cancer in one breast, and you're thinking, we get this a lot. Should I have a bilateral mastectomy? Should I have a double mastectomy? If you were found to have a germline mutation, which would suggest that you have high risk of developing another breast cancer, then there's more options for you to consider surgically. In terms of radiation and then medical treatments, there are also considerations to know whether or not you have these germline mutations when we're thinking about even early stage cancers, which medications, which treatments you're eligible for if a germline mutation is found. Um, those are, I think, the most kind of timely when you are first diagnosed and you're trying to think about what the entire course of action is going to be with the surgery, if radiation is going to be involved, and then if there's any need for medical treatment. Um, Beyond that, after the kind of treatment decision is made, of course, it's important in terms of knowing if there's something in your family that other people could have inherited. So again, this is why I said the most important person to test is the one that has cancer, because that's the highest chance of actually finding um, something that has some significance. And, if it is found that you have something that could be passed through your family, then it will impact the other people in your family in that their screening recommendations could change in terms of the age that screening would start for those people, and also certain prevention methods that could be available to them if they also have the mutation that you do. And so it doesn't mean that everyone in your family has it, but it does mean having those conversations with the family, sharing that information so that they could then get tested and see if they have that same mutation, and then what that means in terms of their earlier screening or prevention methods.
Yes, which can be scary, and I'm kind of reading through a
Yeah.
series of questions that are all around. What are the downsides of getting this germline or genetic testing done? And, could it in fact impact my insurance? Can it impact my eligibility to participate in clinical trials? Would it just cause for, a sister or a child of a survivor, could it just cause anxiety that's not necessary? So maybe you could just, I know that's a lot in one, but talk about,
Yeah. Yeah. So first of all, again, we're talking about not the most common scenario, right? So it's much more likely that you'll have germline testing and it'll be negative. So again, it's not the most common scenario. I know whenever we have the discussion, it sounds like this is going to happen to everyone that has breast cancer. Is just not the case. Most of the time, a significant mutation is not found. That's number one. I think in terms of anxiety, every cancer discussion, I think, is fraught with anxiety. Nobody wants to even say the word cancer. People don't like to talk to me once they find out I'm an oncologist, right? And so no, I'm serious. But there is a big fear in general around cancer, right? And that's why I do have such respect for what cancer patients and survivors go through, because like everyone's afraid of this, right? And so I is there anxiety? Yeah, but I think there's anxiety as soon as you hear you get diagnosed, I think. And so I don't know that that's any different. What I do like to say to people is, I mean, you have a chance to help and empower the people in your family if you do find something. Having a discussion with younger people, really in terms of earlier screening, and when they should start, and if they have a mutation that portends that they have a higher chance of getting cancer, that they will either catch it early or even be able to take preventative measures to prevent it altogether. I think that is such a powerful thing to be able to give to the family. But I think it is also very personal. I guess everyone has to kind of think about that risk of anxiety versus the benefits. The other thing is that families don't like to talk about cancer. Again, I'm an oncologist. There are people in my family that have cancer, and I still can't get the details sometimes, because there is such a fear around sharing this. And I just think we have to start having these conversations in our families. It's so vitally important. We're also seeing cancer demographics, younger people getting diagnosed with cancer. Almost every year there's another study, younger and younger people. And so I think anything we can do to help that is important. I don't know if I answered the question. I think I got on my soapbox. I'm gonna get off it.
I think you did. I think you did. And I love the soapbox speech, because I couldn't agree more. Before I was diagnosed with cancer myself, if a cancer commercial came on the radio or the television, I could not turn it off fast enough. It was just like I did not. So I completely relate to that. But obviously, having gone through it and now doing this as my line of work, the more conversations that I have and the more I'm able to educate myself, it has helped with my anxiety and kind of given me more hope and purpose in diagnosis. So I would just
I think that's really beautiful.
Others, and the one part that we didn't touch on was about it maybe impacting your eligibility for clinical trials. And
yes.
I've been involved in 2 early stage clinical trials now, and I mean, please weigh in, but at least for myself, they will turn you inside out with all the testing. So if there's something they want to know and you haven't yet had that testing, you'll likely have to do it as part of the eligibility criteria getting onboarded. So I wouldn't not do it because you're afraid it'll impact your future.
Yeah, no. And the other thing is there are clinical trials for people who have these mutations now.
Exactly.
Like I alluded to the fact that there are some treatments which are for patients that have germline BRCA mutations now. And that was only because of clinical trials for those patients. So, I think clinical trials, you actually might be helping because you will find yourself eligible for more things probably, if there is a mutation that's found. But I just wanted to say something to you, Suzanne, a little bit off topic, but just about talking about cancer. So I wanted to say something to encourage you. A couple of weeks ago, I was at Essence Festival. So Essence Festival is a huge musical festival that happens in New Orleans. And I was there with my podcast, and we were talking to festival goers about cancer screening and talking about family history. And I thought we were in the wellness house, but I thought no one was going to want to talk to us because everyone else was kind of like derm, blood pressure screenings, the kind of stuff you would normally see at a health screening. But
Mhm.
young people were so open to hearing what we had to say. We were talking about mammograms, but also colonoscopies, that I
Yeah.
was really encouraged. And what I said, a lot of people who had breast cancer and other cancers stopped to talk to us. And people who had already had their colonoscopies, right, stopped to talk to us. And I always say, people want to hear more from you who have gone through it than from me. Yes, we're doctors, we have the expertise, it's important, but I think it makes such of a larger impact when you hear it from someone who has it and kind of walk the walk, and you can give your perspective. So thank you for doing your work.
No, thank you. That's very kind and very encouraging. So I really appreciate that. Um, okay, I'm gonna wrap up the germline genetic questions. So I'm gonna combine two. So the first part is, have we discovered new genes beyond BRCA1 and BRCA2 that kind of everybody in the space is familiar with?
Mm.
Um, and then if so, how often as survivors should we be being tested? So the specific question is, if I was tested 10 years ago, is there benefit for me asking for the test to be repeated?
Yeah, that is a really great question. And I'll tell you why. There are some patients who get diagnosed and like their family history is off the charts, or, they're really young, something that you really have a high suspicion that you're going to find something genetic or germline, as it were, and there's nothing. And it's like, there's got to be something, right? The point is that new genes are identified all the time. And so when I started fellowship almost 20 years ago, it was BRCA1 and 2, right? To your point, now when we're talking about genetic testing for hereditary cancer and breast cancer, it's a lot more than BRCA1 and 2 now, right? So it's BRCA1, BRCA2, CDH, PTEN. There's one called STK11, and PALB2. So these were all genes that we weren't testing for even when I started fellowship. And so I think about, or not, not commonly, right? And I think about that a lot, like patients who we haven't identified, like when do you go back and test? So I think as it's always good to just kind of check in as a survivor. Hey, has there been enough in terms of new genes identified from when I was tested that I should consider testing again? And also, as your family history changes, right? So sometimes um, you're going along and then somebody else in your family gets a diagnosis, right? Your family history is now changed. And so
Mhm.
whenever there's like a change in your family history, I think is another good touch point to bring up with your oncologist.
Okay. Yes. Um, I was one of those. So just if anybody kind of falls into that strong family history, but no identified germline mutation. So I come from a long history of premenopausal under 50 breast cancer, and no germline mutations in any of us being tested. But there is a study going on at Fred Hutch Seattle Cancer Care Alliance. So in patients like me, if there's anybody else out there, you can donate. It's just a blood sample, and they have a bank of that that they're doing research on to hopefully maybe identify new ones in the
Yeah.
future.
So
So we can
again,
develop drugs.
there's that question again of like clinical trials or research, or,
Exactly,
can
exactly.
you participate? And I think it only opens your
Only open.
avenues and your opportunities. But yeah, I mean, candidly, um, you weren't my patient. If you were, that would have bothered me that you had a strong family history and nothing, you were someone that I would encourage to participate in studies and like you're doing. Yeah.
Yes. Well, I followed that advice even without you giving me
Good.
being lucky
I
enough
did not give you
to know
medical advice, by the way.
I know. I know. Okay, thank you. That was really helpful in understanding that. Um, I think that's the last one.
Okay.
Are there any words you want to leave our community with, or words of
No, just thank you for the opportunity. This is one of my favorite things to do, actually, because I think it is so critical for patient support. You know, when you're in the office, our time is really limited and it needs to be pointed often on kind of making treatment decisions and understanding how you're doing with treatments, and really kind of getting through that. And there's so much more that needs to happen that we just don't have time to do, to be honest. And so I really appreciate these kinds of efforts because I think they're so important for the total care of cancer patients. So thanks again for the invite. I hope I helped and didn't
well,
cause more confusion.
you did not. You did not. I think a lot of us will be going back and watching the recording just to, help it kind of absorb a little bit. But just so appreciative of your time and oncologists like you that have such a heart for patients and really wanting us to understand and really wanting to equip us to advocate for ourselves. So just a huge thank you to you for our patients that are listening, and either you wrote in ahead of time or during the webinar and I didn't address your question. It might be because it's just too specific and we can't do specific medical advice on these webinars, but we do have oncology nurse practitioners on staff at Outcomes for Me. And so we'll be following up individually so that you can have a conversation with a nurse about your specific situation and get some assistance there and resources there. So if you didn't ask a question, but you still have one, you can email us at questions@outcomesforme.com. Or enter your question into the Outcomes for Me Ask a Question box in the app. As I mentioned, we'll make a recording of this video available in the app so you can go back and revisit it or share it with other patients or caretakers that might find it helpful. But appreciate everyone's time today, especially yours, Dr. Avery, and have a wonderful rest of your day.
Thanks. You too.
Okay, bye-bye.
Bye-bye.